Yes, sir. Good. All right. The floor is yours.
Good morning. Good morning. All right. Well, welcome to this morning's grand rounds, and it is my pleasure to introduce my longtime friend and colleague, Dr. Elizabeth Ofili. Dr. Ofili is professor of medicine at Morehouse School of Medicine and a practicing cardiologist with the Morehouse Healthcare in Atlanta, Georgia. She serves as chief medical officer for the Morehouse Choice Accountable Care Organization. Dr. Ofili is a national and internationally recognized clinician scientist with particular focus on cardiovascular disparities and women's health. She has been continuously funded by the National Institutes of Health since 1994, with a track record in clinical trials that impact health disparities. In 2002, as president of the Association of Black Cardiologists, Dr. Ofili led the initiative to implement the landmark African American Heart Failure Trial, or AHEFT, whose findings changed practice guidelines for the treatment of heart failure in African Americans. She has helped to raise over $200 million to fund pioneering research and training infrastructure at Morehouse, and she leads multi-institutional regional and national networks funded by the NIH to address diversity and inclusion in the biomedical workforce, as well as community engagement to ensure participation of underrepresented populations in sponsored research. And she is a multi-PI of the Georgia CTSA, which is the equivalent of our ICTS at Emory University, Morehouse, Georgia Institute of Technology, and University of Georgia. She's very well trained, and on a welcoming note, she is an alumnus for her cardiology training here at Washington University. So welcome home, Dr. Ofili, who's going to talk to us about inclusive excellence and why it matters for scientific discovery and health equity.
Thank you so much. Good morning, everyone. Good morning. You got to say good morning. See, I'm from Atlanta, Georgia. You have to respond back. Good morning. Thank you, thank you, thank you. And it's wonderful to be here. And I just want to say a huge thank you to my host, Dr. Angela Brown. As she says, I've known her for many years. She's obviously much younger than me, came into the fellowship program after I did. But I really got to know her through the Association of Black Cardiologists. And I'm going to share how important it is to have networks beyond your immediate program, because it does help in terms of your overall growth. And I also want to appreciate Dr. Andy Cates, who's obviously your fellowship director, and then really appreciate all of you for showing up so early this morning. I know it's not easy. It certainly was a little difficult for me from our East Coast time, but I'm really, really delighted to be here. And as Dr. Brown said, I am focused now on just really identifying and helping to potentially model what we mean by inclusive excellence. So this is something that the NIH is paying close attention to now, and many universities across the nation are involved in trying to understand that. And the reason, of course, it matters is why we're all here, because it matters for patient care that, you know, when they're encountering a physician, they have clear understanding that you relate to them and their problems. You understand their lived experience. And data has shown that it does matter who is representing that physician or scientist in the eye of that patient. Let's see if I can do this. So these are my disclosures. As Dr. Brown said, I do have most of my funding from NIH, and you see there some of the advisory boards that I serve on. I will reference my role with the NIH All of Us program. I will also briefly reference a patented technology that is allowing us to address research at the point of care. So what I would like to do is to frame inclusive excellence in the context of genomics research. I do that because I think it is the easiest way to see how gaps in research is actually affecting clinical care and patient outcomes as we know it. and outline how a lack of diversity in genomic databases actually do exacerbate health disparities. And I would like to introduce the All of Us Research Program and the promise of precision health, primarily because as taxpayers, we need to know how the NIH has invested considerably in All of Us program to try to bridge some of the gap that has existed for many years. And then describe a patient-centered point of care research, which some people call decentralized clinical trial to advance health equity. And I will close with lessons learned on career advancement and mentorship, because I know a lot of you as young investigators are, navigating this terrain right now, and hopefully I can share some of the lessons that I've learned. So when we talk about inclusive excellence and health equity, I want us to remember that we're actually looking at a reimagine and a re-envisioning of this program, of this concept, which really came out of higher education as referenced there. Diversity and inclusion efforts, we should recognize, really goes beyond numbers, right? So if you have one faculty here, two faculty there, 3 students there, 4 fellows there, that is not what inclusive excellence looks like. Inclusive excellence actually looks like, and data shows, do these faculty feel like they belong? Do these faculty and students feel like they're supported? Do they feel like they're prioritized? Now that's important, because no matter who we are, if you happen to be in a minority group, there are things that you encounter that majority population do not encounter. And if we're not sensitized to that, the few numbers that you have will go away, because people don't want to go where they are not wanted. So scientific discovery with a health equity lens will ask the following questions. Who is doing the science? What science is being done? And who is at the table, and who ultimately has access to this research? There's actually a quick example of this from, I know Dr. Angela Brown shares that with her fellows and students. When she mentioned the African-American heart failure trial. When this study was done, who did the science came from around the country. Everybody who had heart failure patients that were African-Americans, because it was a self-identified, a trial that in self-described African-American patients. The science was to bridge the gap in heart failure care, because there was significant disparities, and it was clear that drugs that were available were not working as well in African-Americans. Who is at the table during the advisory? Well, the Association of Black Cardiologists was at the table, and we ensured that a number of the clinicians participating were actually African-American or Black physicians. Then who has access? And here we're not talking about a trial was done, it was approved by the FDA. Who has access to the drug, to this therapy that we all work so hard to get to fruition? And it turns out that many African-American patients still do not have access to the drug. I'm not going to present that today, but I can tell you that I did an analysis in the Medicare Medicaid database, and it turns out that many African-Americans were not getting drug. I have patients that I have to plead with the Medicaid Georgia to make sure they get the drug. And again, as Dr. Brown and I were incidentally talking about, getting a drug approved and making sure it has access in this country has many layers. Some of those layers include who's a pharmacy benefits manager. First of all, who's the manufacturer of the drug? Who wants it advertised and sold? Who's a pharmacy benefits manager that decides what formulary goes on? Then that a patient can go to a pharmacy and get it. It is a convoluted process, and many of our patients suffer. So clearly this is beyond science, immediate sciences, we know it. I just want us to understand that when we talk about inclusive excellence, we are asking these broad questions. And even as cardiologists and clinicians, we should always ask our patients, what was your encounter in the pharmacy? Did you get the drug I prescribed? Because sometimes they do not. That's a topic for a different session, but I do want us to think about this. And I want to credit Dr. Hannah Valentine, who was she was the Chief Diversity Officer for Scientific Workforce at NIH. And she led a number of these initiatives. And before she left, it culminated in the first FIRST capital program that I'll mention before we close. So in terms of genomics, and again, you will have access to these slides because they'll be posted. So I'm not going to read through all of this, but I just wanted to center the conversation in us understanding that. So the National Human Genome Research Institute at NIH was really asking a question. They knew they had a problem, just like NIH has acknowledged recently. We have a problem with racism and systemic racism. And NIH Director Dr. Francis Collins in March last year apologized for this and set out a big opportunity called the Unite Initiative to try to address this program. And across all of NIH institutes, they're all looking to see what do we need to do as an institute to address the program. And within the, I just want to make sure, is that clock correct? It says 7:45. Okay, so I'm good. All right, thank you. So the Unite asked all of these institute directors to look at their individual strategic approaches and see how can they be more diverse and more inclusive, right? Both in the intramural program, which is a significant effort at NIH, and the extramural program, which is the rest of us across the nation, how we're involved with NIH. And the National Human Genome Research Institute came up with these, and they have shared it online, and they are now doing all kinds of stakeholder engagement, which is one of the ways you try to make sure you're collecting good engagement from your community. They want to strive for global diversity in all aspects of genomics research. Now, that is actually better science, because the more diverse your focus, the better. And that actually has nothing to do with human diversity at this stage. They want to maximize the utility of genomics for all members of the public. Again, that is good science, right? They want to champion a diverse genomics workforce. Clearly, that is good science, because the more diverse your workforce is, scientific data and evidence has shown, the more likely you are to ask the right questions, and the more likely you are to get to an answer that serves everyone. And finally, they want to provide a conceptual research framing that consistently examines the role of both genomic and non-genomic contributions to health and disease. Why does this matter? Well, we've learned now that obviously genetics is, once the human genome was fully defined, that all of us are pretty close together. So what matters in terms of health and disease goes beyond our genetics. Our genetics are, of course, critical, but here we're looking at what we are now calling the social determinants of health. And you'll hear that reference again and again and again. It's about what's the lived experience, who has what risk, what are the environmental stressors, et cetera. They do matter. And so this is, again, I love this slide because it begins to say what Dr. Brown, what Dr. Cates, what all of your attendings, what you all are encountering within the healthcare system has a lot to do with the outcome of patients, right? And you see some of the ways that the Human Genome Research Institute is trying to think about this. Quality improvement strategies. What does that mean in terms of how genomic medicine or precision medicine is being accessed in the practice of medicine? How does that affect outcomes and how that data is analyzed? That's really important, because when everybody started to talk about precision medicine, everybody thought, well, we just need some technology, we need to make it great, and we need to just run these analyses and throw the results at the doctors. Well, as clinicians, you look at this and say, what's actionable here? If I have nothing that's actionable, I'm not going to do anything. So again, these are all steps in the process, and it does build from the basic science, as you see there on the screen. And so inclusive excellence intersects with health equity. So I love this discussion from Dr. James Hildreth at a recent NAGRI workshop, where he says, to achieve health equity, we need more inclusive genomic research that will lead to improved genomic medicine opportunities. Obviously, everybody's not going to do genomic research, but how do we create that access so even if you're not involved in genomic research, the data that's coming out of it is accessible to you? And again, Dr. Hildreth, as president of Meharry Medical College and himself a renowned scientist in HIV research, understands what this means. And it's not often that you have the head of a university, such a big scientist. So what he says, in my opinion, really matters. But these are some of the challenges that we all have in this situation, and not unlike the broader challenge in healthcare. Health disparities in genomic databases exist when you think about diverse populations. And why is that? That is, of course, if you see on the right-hand side of the slide, in terms of who's involved in that database, it is extremely Eurocentric. And because it is Eurocentric, that means the data that comes out, whether you're looking at BRCA1 or the LDL receptors, or looking at prediction of diseases, prediction of blood pressure, or even looking at opportunities for personalized medicine approaches and pharmacogenomics, all of that is going to be tilted toward what is in your database. So again, that is a challenge. And the NAGRI, for short, or the National Human Genome Research Institute, recognizes that. And this is just that information in the graphic. If you look at African ancestry participant on the extreme right versus European ancestry participant to the left, you see how there is a problem with diversity within the database. And there was a real analysis that was done and published that showed that using something like polygenic risk scores, which all of us understand that our respective diseases that we treat, like diabetes and high blood pressure, it actually takes many genes interacting to lead to disease, and certainly with obesity, which is a classic example. So in order for you to get to that, you need to look more broadly at these polygenic risk scores. And how can you do that if you do not have a database that reflects the broader population? So we are then dealing with imprecise medicine, which exacerbates disparities. And it's very difficult to have actionable information for clinical practice. And so one of the lessons that Dr. Hildreth left us with is he called it the importance of social determinants, or the 6 degrees of separation. And here, you start out with all of the 5 degrees up there, which are huge. And of course, this is stuff that we talk about in healthcare all the time. It goes beyond the walls of the university. It goes beyond the walls of the healthcare system. You are looking at initially through your pipeline, who has access to education resources, who truly has access to quality healthcare. How did that patient get in your emergency room? How did that patient get from your emergency room into your ICU or to the beds you have, right? What neighborhoods do people exist in? And what is the social and community context that that individual lives in? And importantly, what is the economic stability? So these are not unusual concepts, but they previously did not factor in how we look at science and healthcare. And now these are known as social determinants of health. The NIH has a huge effort with this, and they developed what is called the PhenX toolkit, PHEN, and then X toolkit. And if you look it up, it has all of this data that allow you to ask the question, regardless of what research you're doing. If you include social determinants in there and how you will measure it, and sometimes you need help with people who do this research, the social scientists to help you, that actually increases your opportunity to get funded. Again, this is another talk for another day, but it brings up the notion of team science, how you can't solve all the problem with you as a cardiologist or you as an internist or surgeon. You got to bring in others. And of course, there is some role with technology, and I really buy wholeheartedly into that, but it is not technology for the sake of technology. It is really technology for the sake of elucidating and highlighting what is possible to bring everybody together. I mentioned I want to highlight the All of Us program. I think the All of Us NIH research program is an opportunity to learn some things, but more importantly, because of the amount of resources directed to it and the large data that is being collected, I do believe all of us, if you don't know about this, make it your business to know about the All of Us study. Of course, I have a little bit of a bias here. I am on the National Advisory Board, but I have seen the benefits and the advantages of participating in the All of Us program, and you'll get to see some of it. This was directly from Dr. Josh Denny, who was previously at Vanderbilt and is now the CEO of the All of Us program at NIH. I invited him to present to our RCMI consortium in a recent meeting we had, and he opened up his slides and said I could share them widely. So you are the beneficiaries of that because I am sharing some of his slides. And as you can see from the beginning, the All of Us program titles itself as improving health through technology, and again, using the power of data by bringing in diverse communities. And you see sort of a visual of what diversity in that context truly means. And I'm not going to go through again the details of this because you have access to the slides. go ahead and review that. But their mission is really about nurturing partnerships, making sure they are bringing the richest biomedical cohort to bear, and catalyzing an ecosystem of not only patient communities, but scientific communities, and making sure together we can see what's possible, and not only see, but create significant outreach approaches to address human health problems. And you can't read the fine print of this, but I put it here. This is from the original New England paper that talked about the methodology and the approach. And the big things you're going to see here is it invites lots of clinicians to participate. It invites lots of patient cohorts to participate. And not only that, it creates a large biospecimen repository and makes access to those repository. And I'll just dive into that a little bit. So these are what things are as of February 28th of this year. You can see there's close to 500,000 participants, including almost 300,000 electronic health records, because that's what the patients sign up once they sign up, that you can have access to my EMR. And then the participants who have actually completed steps in the program, over 300,000, and biosamples are available in more than 340,000. Of course, COVID interrupted some of the work, but it's now about to be back online in terms of in-person. But what you're looking at here are the demographics of who's involved, specifically what they call UBR category, which is underrepresented in biomedical research. And as you can see there, they have prioritized participation in race ethnic populations, ensuring that there's good income diversity in participants, and ensuring that rural Americans, whether they're white or Black, are properly represented. And the data collected from all of us participants include, as I mentioned, electronic health records based on consent, participant surveys, which is a huge part of the data, physical measurements, because people do come into research centers to have these physical measurements done, as I mentioned, biosamples, and probably of interest to a lot of us, mobile wearable technology, which a lot of patients have access to, is also part of the database. I love this about the All of Us program, and we're modeling it in our own research. What does it mean when you're collecting data on patients who actually return results to participants? And it's got to be something they can use. And what you see here is sometimes this is about hereditary disease risk and pharmacogenomics. And sometimes patients are interested in that, but sometimes they're actually interested in what about me and now and what's happening to me? Can you share some of that result? And again, the All of Us is doing a good job of sharing some of the immediate work with a future opportunity to share more. The public has access through a browser, and these are the kinds of things that the public has access to. And they built it into the research. Scientists have an access through what's called a researcher workbench, and that's you can go online and find out about that. But I have to confess, there's some limitations. Sometimes you have to know our statistic, which I clearly don't know. I need other people to help me with that. But understand, bringing your informaticians to participate in that, and the All of Us workbench group will come in and train and help you get online. That's important because there's a lot of data that people can have access. And now the NIH All of Us program is actually going to be putting out, with recommendation from the advisory board, putting out funding opportunities so people can use the All of Us data to answer questions. But who is participating right now? Right? We mentioned that obviously we've got a lot of individuals, diverse participants in it, and which is good. What about the scientists that are participating? Let me just stroll very quickly through here. These are the research diversity. As you can see here, there's still a gap. African Americans and Latinx participants, not as high as we would like. But then when you look at the career level, they're doing a better job of at least targeting early stage investigators. That is actually one of the reasons they brought Kareem Watson on board recently. And again, he's doing the rounds, making sure to talk to individuals about participation. And I know Dr. Victor Davila runs the Pride program here, and I'm sure he's very much aware of the All of Us program and the opportunity to bring in some of private participants into this research program. Within the RCMI, when they met with us, they talk about a data use agreement. That's what has to happen initially for physicians, for scientists to have access. And these are just RCMI institutions. We have 21 institutions that are part of our consortium. And as you can see, the majority of them already have data use agreement, but we're now doing an effort to ensure that 100% of those institutions have implemented data use agreements. You have to have that before you have access, but in the case of the all of us, it's a very short process. So if you are not yet active in that, I hope you will. I'm going to transition now to just talk a little bit about what the RCMI, what I believe the RCMI consortium brings to the table. And this is just mentioning the fact that as a consortium, I believe, again, I'm biased in this obviously because I wrote this paper, that we have a blueprint for inclusive excellence. So why do I say that? Actually, I joined the RCMI Coordinating Center as a leader back in 2014. And at that time, what was immediately obvious to me that these 21 institutions are congressionally mandated by Congress to be funded using a competitive research program every 5 years, a competitive proposal application process. But they then bring to the table, these are institutions like Morehouse School of Medicine, Meharry Medical Center, historically Black institutions, including pharmacy schools like FAMU, Texas Southern University, and a number of them total, and of course, Hispanic serving as well, University of Puerto Rico, Native Pacific Islanders like University of Hawaii. So all of these institutions are serving diverse populations, and they tend to recruit diverse students and diverse faculty, especially addressing some of these underrepresented groups. So the RCMI program is designed for these scientists to be brought into the mainstream in terms of their research, in terms of their funding opportunities. So this is an infrastructure that supports their respective institutions to do that. A number of them are primarily basic science institutions. And so within that, we have a number of clinical science institutions, which are medical schools like Morehouse. And we have discovered that working together across that translational spectrum, we are able to ask some critical questions. And what I found is it really requires understanding what works for whom and in what context. And evaluation of, if you say you're doing inclusive excellence, should include the institutional context. So if Washington University decides we're going to do inclusion excellence, we need to understand the institutional context at WashU. We need to understand who's at the table. We need to understand who's doing the science. We need to understand who's the community we're serving and who has access to our research. And then we need to understand, because we're not all, when many of us, most of us are not there, where we're starting from, what are we measuring, where we want to get to, what are we measuring? And you're going to hear some more about that because I took this blueprint paper and I submitted it with my application to be a coordinating and evaluation center within the first program that I'll discuss later. And fortunately, the reviewers liked it. So we now have, in addition to coordinating the RCMI Center, we're coordinating that first program. And I'll talk some more about it because it's an exciting program that could potentially change who is participating in science and in an inclusive manner. Nobody is being excluded. We're just bringing in more people so we can answer real questions and improve human health. But this is the challenge. Several years ago, Donna Ginther from Hopkins published this paper, and that is bringing to light what many of us already knew for many years. And that is the fact that R01 funding and R01 reviews at NIH is biased. It is biased against Black Americans. It is biased against physicians or investigators who are applying from, well, less known institutions. And I've been on study section, and a number of the people listening have been on study section. When you're on NIH study section, it's a group of people around the table that are peers of the scientists. And we have to make a determination about whether this is good science and whether this science will change the field. A lot of the times, if you're applying from a Harvard or a WashU, you're known because you've already done groundbreaking science. And the tilt is toward your science and your scientists than a school like Morehouse School of Medicine. I experienced this when I shifted from St. Louis University and Washington University to Morehouse, right? However, this is a problem because that means the science that's being proposed at some institutions who may have more access to diverse patients and can answer the questions is not being funded. So the NIH embarked on a major program called the Diversity Program Consortium to attempt to address that, one of which is the National Research Mentoring Network. And we were fortunate to be a participant in that and have science that's being funded through that. Again, the Ginther paper is looking at the US Census to the left and NIH principal investigators to the right. And as you can see there is a huge gap. Blacks represent 12.6% of the population and only 1.1% of our funded investigators at NIH. And so many of us propose different opportunities at Morehouse. Our opportunity is actually looking at coaching and using a developmental network process to attract young investigators, early stage investigators, and help them get their research funded. So these are people who participate in the NRMM program and at Morehouse, and I just want to give a shout out. As you can see, we have diverse scientists that are working, and we also have, I want to mention here to the right, this is our project scientist, Dr. Jessica Focal-Badger from NIH NCATS, for working with us to ensure a collaboration that will get to the goals that NIH is looking for. We have brought in cohorts of investigators to participate, but I just want to mention our theoretical construct here, right? We are actually looking at the notion of social capital. We are not looking at a deficit model to say, oh, woe is me, we don't have enough. This has relevance to all of you as young investigators. You are looking to say, I bring something to the table. I just need to understand what that is. I need to know for myself what I'm bringing to the table in order to actually bring that to the table. And sometimes when you're either a minority or woman or someone who's been underrepresented, you are not certain of what you bring to the table. It is important that you explore that because what you bring to the table can be enhanced by the research environment, but people have to know what are those personal characteristics, what is your science identity, and how do you bring that to try to address some of your outcomes, as well as how your research will be impactful. We have brought in a cohort of participants. We've done 3 cohorts now. We're currently recruiting our 4th cohort. COVID created a problem for us, but we are back on track. These are some of the data that we've published based on our work. And we are obviously working hard to overrepresent African Americans and Latinx communities as our target population. But as you can see there, we still have many whites that are participating, many Asians that are participating. So it's important to know that this is not just about underrepresented, this is about inclusion. Because the more of the diverse American community, scientific community we bring on board, the more likely we are to answer the questions. So I'm going to pivot here to why we're all here. We're all here because there's healthcare issues and healthcare disparities. And in my lane where I sit, it's about chronic diseases. Because as a cardiologist, that's all I see. 6 in 10 Americans are affected by this. And the challenge for us is there are huge lifestyle factors. And the challenge for us is many patients have more than one disease. And the challenge for us is those patients are frequently not able to engage because they too are dealing with life. So how do you address this when you are trying to solve a problem, whether at the healthcare level or at the scientific level? I think you need to recognize that patients are overwhelmed by all of the factors that we stated here. They are coming up with conditions that are not well controlled. They're dealing with life. They're dealing with what happens with them, dealing with seeing all these, having all these MD visits. And we know all of this, so I am preaching to the choir, but I think it's important that we consistently verbalize that and acknowledge that when a patient is sitting in front of us. It makes a difference. And I just want to highlight the work of Dr. Priscilla Pimu. She is one of our professors at Morehouse on the TED stage. And this TED program really resonated across the nation with over 2.1 million people that have viewed it and are commenting with her. She was talking about Health 360X, again, declare my conflict. This is a technology that we developed at a Morehouse School of Medicine and is being used to help patients and coaches and physicians engage in care in chronic disease. So she tested it out among diabetics, and the study was funded by NIH and NIMHD, and more recently by the American Heart Association, using the American Heart Association's Life's Simple 7 concept. And what she's finding is actually beyond the broader outcome. There are questions underneath, and she uses an example on her TED Talk, and I just encourage you to listen to it, because she talks about context. Who is hearing what you're saying when you're a physician? What does that communication look like? And it is not just enough to take immediate intake. In the 3 or 5 minutes you have, we find that these coaches working with the patients make a difference. But importantly, understanding, this is the concept here, is there's a theory base to behavior change. Patients have to feel that they're accountable, but they have to be motivated, and they have to be able to have a system that allows them to access and engage in care. And as part of this analysis, Dr. Mohammed Idris, who's one of our new recruits to Morehouse, he's a social computer or social scientist, as he calls it. So he does both social behavior as well as data science. And what he did was he analyzed information that they have recorded from coaches and participants, and he's documenting what a coach is hearing versus what a patient is saying. And interestingly, there's a dichotomy, and again, you can review this in your own time, but that dichotomy says, sometimes if a coach is communicating, they are communicating around, you must do this, do this, do that. And a patient is communicating, he goes, I have some stressors that's keeping me from doing this, and doing that. And sometimes the coach is here, yes, you have stressors, but a patient is saying, my stressors are specific. I have financial difficulties. And at the end of the day, what they found was that there's a difference in the achieved topic proportions, and this is a science called topic modeling. So when he looks at the topics of the coaches that were successful on the left versus what they were interrogating within the participants, these are folks that were talking about social determinants, that listened to the patient's conversation on social determinants versus some of what they wanted to transmit about knowledge about diabetes, about what the patients should do. And this is very different from those coaches that did not achieve outcome that was desired. They all, they might be emphasizing healthy eating, but not looking at other things. So you can see here where you're talking to a patient, you say, you got to eat right, you got to eat right. The patient is looking at you and go, yes, yes, yes. But, I got issues that I'm not eating right. Again, this might seem boring. I have become really, really excited about this research because of the opportunity to make change. And again, in our opportunity includes a small business innovation research that was really, really, to my utmost delight, approved by this study section, which are technology people mostly, and doing all kinds of research that we don't normally do, but they found value in it, and they have approved us for what's called a fast track. And that is designed to address a major initiative that NCAT is interested in, and that we were just sharing, to bring research to communities of physicians who are not normally participating. And for us, these are 1-2 doc practices, members of the Association of Black Cardiologists who want to engage but don't know how. So we are bringing research infrastructure to them through what we call the CIVIS registry, and then we are engaging them in the participation through this NIH-funded research program. So let me just close here by just sharing with you, whenever somebody is in front of you, they have arrived there through any number of ways. Some of them more painful, some of them they would rather forget, but regardless of what pain is and how that affected you, that's a part of your growth. It wasn't painful to be at WashU, so let me be clear. But I learned a lot. Victor Davila, as I said, was my colleague. Michael Rich was my attending, and he is a young guy. He was just a young attending, right? I have Bob Kleiger, who was people thought was more my nemesis, but you know, he just had a lot of opinions and I had a lot of opinions. And if I had to do it again, I would probably have less opinions in front of a renowned cardiologist and listen more, right? So that's my lesson learned. And then of course we have Ron Crone, who's an attending. So we, thanks to Dr. Brown's generosity, we all got to participate in a dinner last night. And I have obviously had an opportunity also through St. Louis University to be part of an ECHO fellowship that helped me advance my career as well. And I did some of my research there. And as you heard at Morehouse School of Medicine, I have done the type of research that, you know, I couldn't obviously present all of it, but I shared some highlights. But all of this is important because I was not alone. And the more you learn when you advance is that the more people you have around you is your mentor, but it's also people I call now developers. And some of those developers are your colleagues, and bringing them along is very helpful. Again, I'm fortunate to have had some leadership opportunities, as you see reflected there. And those leadership opportunities I'm learning now don't really matter if you don't bring others into the space. And I just want to round it out by really, really acknowledging and thanking Dr. Brown, because she's a true leader. Because when she called me at 7 o'clock this morning, you don't want to know what my hair was like or what my face was like. I was like, oh my God. And she goes, it's okay. It's okay. Take your time. And so here I am, a professor of medicine. I thought I've done all this stuff. This is the kind of voice that a young investigator will hear to know it's okay. It doesn't always have to be perfect, but you show up. And I really, really thank Dr. Brown for that soothing voice today. I want to just close it out with the first program. I know you guys applied. Hopefully you get it. From a communication evaluation standpoint, again, Morehouse, I am pleased, was funded to address this problem as a coordination and evaluation center. These are the people we brought together for the first program. I want to just acknowledge Dr. Yulia Strakalova from the University of Florida. She has brought in an innovation in evaluation called the Really theory of evaluation that's helping us. Dr. Daniel Sarpong, formerly at Xavier, now at Yale, are just a well-rounded evaluator with lots of experience. And my colleagues that you can see here, and of course, Linda Pololi from Brandeis, who is modeling a well-validated instrument called the Sea Change Faculty Survey. And the goals you can read in the FOA is to address what I shared earlier. We've got to foster career development for new faculty. And if you get a first grantee, if you are awarded, you're expected to bring a cohort of early stage investigators, support them and help them develop strong research. And of course, I do acknowledge a lot of people that I mentioned along the way who have helped me with this presentation. And most importantly, my patients and the staff at Morehouse School of Medicine. And never forgetting my family. I just want to brag. This is my husband, Dr. Chimlo Nobialo, who also trained with me at here at WashU. He was a nephrology fellow. And my mom here, who's very much still with us for that, we're grateful and really helped. And that's the reason I'm able to have all these 4 adult children, because I did have support at home. This is my oldest, Tim, my daughter, first daughter, Shimite, second son, Chris, and my youngest daughter, Felicia. All of them doing different things. Felicia is in a psychiatry program as a resident at University of San Diego. Ashimita is an attorney who just decided, after working in corporate and my husband thought she was set for life, she decided, they're stifling my creativity. I'm going to be an entrepreneur, which means she's back at home. My oldest son, Tim, who's interested in a lot of different things, and he's still at home. And my son, Chris, who's an artist and a lot of different things too. His apartment got flooded and he's back at home. So there you have it. We are a wonderful family and I love every one of them. And thank you all very much for listening to me. I appreciate it.
Thank you, Elizabeth, for that awesome presentation on inclusivity. And I think it's something we can all relate to because it's all for the benefit of our patients. So we have time for questions, and I'm sure there are quite a few. And we're going to start with Roland.
Good morning, Dr. Ofili. Thank you very much for a very wonderful talk. You brought up something that I think when I talk to some of my colleagues that we went to, med school, we always struggle with, and that is that some of us come from minority communities. We always want to go back to where we came from or work in disadvantaged communities, and we always struggle with this question: if I go to work in that community hospital, and I'm also interested in pursuing research and looking for money to pursue this research, am I at a disadvantage because I'm working at this less known community hospital versus me staying at WashU, where I know that it's a big name institution? So you brought up the fact that the NIH has recognized that there is a bias between me coming from WashU and say one of my colleagues coming from a community hospital. I might have missed this, but now that we've recognized that there is a problem, are there steps that have been taken to say, hey, if I'm submitting my grant from WashU versus my colleague at a community hospital, what has been instituted to say, hey, we're going to give equal attention to both proposals, irrespective of where I'm coming from?
Right. So that is a very, very good question. It has a comprehensive answer. I'm going to give you the short version of it. So first of all, the reason for that bias is not necessarily wrong. It is that submitting a research program, at the end of the day, the taxpayer dollars need to find value. They need to make sure that research can be completed and that data published. So with that recognition, you're going to where you found results, right? WashU. But at the same time, in the community center, you have physicians who may want to participate. So what I learned as part of the solution is, number one, if you don't want to leave WashU, that's fine, but expand your research horizon and bring in others, right? In my case, I left. Part of it is it's what what the track that I had and that the opportunity that was open to me. And I started out in a small community in Alabama at an FQHC. I still continue to do research, but it took doing a lot of other things after hours. I'm not necessarily recommending it to everybody, but I'm saying there are ways to overcome some, biases. And I encountered some of that at Morehouse, but when we were starting a training program, we got a rejection first with an R25. And then one of my mentors told me, just cling to Emory and cling on as tight as you can. So I came back with a resubmission, and I had Emory advisors, I had Emory mentors, and I was just clung tight. And because we also had a CTSA where we were already working together, it was credible in study section. So I'm saying there are ways to collaborate, but it's got to be credible so people can look at it and say, oh, this was not just a wedding, an engagement overnight. This is a sustained effort where they can work together, but it's still going to be your research and your science because you're at the table asking the question.
I can help address a little bit of that. So my name is Corey Levine. I'm one of the basic and translational researchers, but also cardiologists here. So I'm incoming chair of one of the study sections. And so the NIH is trains now and instructs us that the key component of this is the environment score.
Yep.
And the retraining is that the environment only has to be, should only be judged on whether it's suitable for the research being proposed. And so that's a recognized problem, and that's a solution to try to deal with that. There's also additional grant mechanisms that are specific for institutions that are smaller, that receive less NIH awards than others. So
yes,
it sounds like the NIH is taking multiple efforts with
Yeah.
the study section level, as well as providing additional programs.
that is absolutely true. Thank you.
So I also like to encourage those who are on Zoom. We have a number of folks there. If you have any questions, to please put them in the chat. Just along that same line of, you mentioned, the multiple programs, especially from NIH, to support diversity in the workforce, diversity in our scientific processes. How are you seeing academic institutions respond to this, particularly when it comes to the promotion and tenure process,
Right.
because that's typically not what we think about.
Yeah.
Team science and
Mhm.
health disparities work
Right.
in that regard.
Right.
So what do we need to be
Yes.
thinking?
Another excellent question. And that's still a huge opportunity. There are challenges, right? Because again, tenure traditionally, you're looking at what have you done and you as an individual. And we're talking now, I just mentioned team science, collaborating. So now some, and I know WashU was one of them that came out early, looking to figure out how to allocate, a contribution. When you have a tenure packet and people who are multi-authors, it used to be only the first and the last author mattered. And if you're a younger scientist, your chances of being first is if you did all of the work, and last you're not going to be unless you're senior author. So now authors in the middle, as long as you're very clear about what did you contribute and put that in front of tenure. And some tenure groups are looking at that, but there's still a long way to go. The CTSAs were initially tasked to address this, come out with recommendations. I don't see where that has moved as fast as we would want it to. The first program is going to take a stab at it and look at, because we have policies that's included as part of our evaluation to say, what is your tenure policy? How are you ensuring the progression of these new scientists that you're recruiting? So I think, you have an excellent question. That job is not done. But all of us, again, in participating either on the tenure committee, evaluating when an underrepresented minority is on your campus, you put them on service duties. What does that service duty earn them in terms of going forward? Because that has value. It's obviously not the most important thing, but it's got to be factored into the calculation.
A comment to build on what you had said with developing the pipeline, I think is so important. I think recognizing what the ACC has done at several levels. One is the Young Scholar Program, which many state chapters have been involved with, which recognizes high school students and some college students, and particularly an underserved and underrepresented in medicine, to bring them to the ACC annual meeting and then provide mentorship over the course of the year.
Right.
And then more recently, two programs, one to engage Latinx and the other to Latinx and other unrepresented medicine, and also engage women in cardiology, specifically residents, to engage them early on too, and kind of really improving the pipeline. So
Right.
just other steps that need to be taken to improve.
Absolutely. And again, all of these in their totality, we have to, and NIH is wanting to do that more through the Unite program, evaluate all these pipeline programs they have, what's working and what's not. And if it's not working, why not? And not be afraid to restart some things. Yeah, thank you.
Any other questions? Any questions in the chat? Okay, well, if there are none, thank you all very much for your participation, and thank you, Dr. Ofili, for a wonderful presentation this morning.
Thank you. Thank you very much.